Hello everybody. Today's topic is acute kidney injury and we are going to discuss the complications of dialysis. So the first complication is infection. Infection in patient with the hemodialysis is major reason for their increased morbidity and mortality. The commonest source of infection in the HD is access site related infection. Other infective foci include pneumonia, skin, soft tissue account for about 42%. Further, about 80% of this infection occurred into the community setting and 44% need in hospitalization. Infection transmission typically occur during the start or at the end of the HD session. Patient on the HD, they are at greater risk of the infection, particularly bloodborne infection as compared to the general population. The main reason occur due to contamination from the service provider when strict infection control measures are not implemented. The increased risk is mainly due to improper hand hygiene, cross-contamination of the instrument, mishandling of the intravenous medication, inadequate disinfection of the dialysis equipment, and failure to adhere to infection prevention and the control standard practices. Furthermore, the patient undergoing HD have the increased risk of infection due to negative impact that HD has on both the innate and the acquired immunity. Uh, in addition, more than 50% of the patients with the end-stage renal disease are hospitalized due to infection. The predominance of infection in these patients are suggested due to uremia, while infection risk is reduced after managing the uremia. Furthermore, the report supports the early initiation of renal replacement therapy for end-stage renal disease due to uremic complication. Now the bacterial infection. Bacterial infection occurred because of the Staphylococcus aureus, Coagulus negative, Staphylococci, Pseudomonas aeruginosa, E. coli, Klebsiella, Enterobacter are the most reported causative organism of the bacterial infection. Patients on the HD are generally more liable for the gram-positive bacteremia, mainly Staphylococcus aureus. HD access infection causative agents are mainly Staphylococcus aureus and COMS. Gram-negative bacteria are commonly grown from the first sputum culture of the patient and the community-acquired pneumonia in HD and CKD patient. It was reported that mortality due to cardiovascular system complication appeared to be exacerbated by the magnitude of HD-related infection. Although the death rate in the patient on HD increases threefold due to infection, recent US data has shown a salutary reduction in the death rate attributed to HD-related infection from 43 to 19.4 deaths per 1,000 patients per year. Previous studies reported that patients who were dialyzed via HD catheter and had hypoalbuminemia, diabetes, and anemia, methicillin-resistant Staphylococcus aureus colonization were at higher risk for developing septicemia. Now the next is viral infection. The commonest viruses in the HD patients are hepatitis B virus, hepatitis C virus, and HIV, which are usually transmitted parent. The increased risk of this viral infection in patient on HD is mainly due to suppressed immunity, poor implemented infection control guideline, community virus prevalence, and possibly shared machines. Other viral infection. The frequency of hepatitis G virus in normal people is very low, but it is more common in patients with HBV infection and it is a relatively more prevalent in HD patient with uncertainty regarding pathogenesis. Now, the BK virus infects up to 90% of general population and it occur more commonly in patients with the renal transplant and those on the HD. Immune suppression is considered an important risk factor for BK virus reactivation in CKD HD patients. Cardiovascular disease. Cardiovascular disease is common complication associated with both CKD and hemodialysis. It was reported that burden of cardiovascular disease in patients with long-term HD is increased by 5 to 10 folds compared with general population. Moreover, the cardiovascular disease complication, mainly IHD, accounted for about 50% of death in those patients. In United States, cardiovascular disease accounted for more than 50% of death in patients with end-stage renal disease, with about 38% dying from arrhythmias and cardiac arrest. Hypertension is not uncommon in patients with CKD and those on long-term HD. The strict control of hypertension in those patients is a critical in reducing further kidney damage and heart-related complications. However, hypertension control is difficult in the CKD and end-stage renal disease, and patients often require multiple drug combinations. In addition, the high calcium phosphate product in CKD and end-stage renal disease increases the risk of vascular calcification and IHD. Anemia is well-known complication in end-stage renal disease, and it can be due to multiple reasons such as erythropoietin deficiency, hemorrhage, hemolysis, and blood loss during HD. Anemia alone is one risk factor for CVD in end-stage renal disease and patient on hemodialysis because it increases the risk of cardiomyocyte damage from low oxygen delivery and endothelial dysfunction. The incidence of acute cardiovascular events such as arrhythmia and cardiac arrest is higher in first week of starting HD, mostly due to early systemic inflammatory reaction and endothelial dysfunction. It has been reported that HD-induced left ventricular regional systolic malfunction correlates directly with the serum C-reactive protein and other inflammatory marker before starting HD. At the beginning of HD, the complement system activation occurs and activate the leukocyte that initiate the pro-inflammatory changes in cytokine transcription profile. Inhibiting complement activation may reduce this downstream effect and thereby decreasing the risk of CVD. However, routinely administering heparin during HD has not been shown to effectively suppress complement activation. HD via central catheter or AV fistula increases the cardiac output, and this in turn increases the risk of regional left ventricular hypertrophy and endocardium ischemia. Conversely, the closure of fistula improves the concentric and eccentric hypertrophy. Furthermore, reducing blood flow to AV fistula may ameliorate cardiac structure and hemodynamic changes in some patients undergoing hemodialysis. A low level of T3 occurs in CKD and long-term HD patients. Low T3 is strongly related to the left ventricular hypertrophy. And low serum T3 is the cardiovascular complication marker in CKD and long-term HD patients. Now, the next complication is amyloidosis. Amyloidosis is the rare group of heterogeneous disorder characterized by the extracellular tissue deposition of abnormally folded protein called amyloid. Amyloid deposits are formed from soluble protein, which undergo misfolding and subsequently aggregate to form insoluble fibrin, leading to progressive organ damage. There are many types of the amyloidosis, such as hereditary amyloidosis, acquired systemic immunoglobulin light chain amyloidosis, reactive systemic amyloidosis, and beta 2 microglobulin dialysis related amyloidosis. Moreover, the amyloidosis can affect the different organs such as brain, liver, kidney, joint, hence leading to variety of clinical presentation depending upon the type, site, and amount of amyloid deposition. Mortality and the renal prognosis are significantly related to serum amyloidosis level. It was reported that a death risk was about 17.7-fold more in patients who had high serum AA concentrations. Amyloid protein deposition occurring after long-term HD is referred as dialysis-related amyloidosis. Dialysis-related amyloidosis is the disabling disease characterized by the deposition of amyloid beta 2 microglobulin fibrin in different body tissues of the patient with CKD and end-stage renal disease. In healthy individual, beta 2 microglobulin is filtered by glomerulus and then reabsorbed and catabolized by the proximal tubule. In patient with the end-stage renal disease, the serum beta 2 microglobulin concentration rises by about 60 folds or more. In end-stage renal disease with HD dependence, amyloidogenic protein retention has been attributed to dialysis membrane, prolonged uremic state, and decreased diuresis, advanced glycation end product, and elevated level of cytokine and dialysate type. Furthermore, cytokines such as interleukin-1, tumor necrosis factor, interleukin-6 production, complement activation are induced by HD and promoting synthesis and release of beta 2 microglobulin by macrophages. The essential method to prevent amyloidosis is by preserving the residual renal function as much as possible to reduce the serum beta 2M microglobulin concentration. Beta 2M amyloidosis is a serious complication of long-term dialysis, especially after complete loss of residual kidney function. HD duration is the major determinant for dialysis-related amyloidosis complication. The risk of amyloidosis is higher when HD is conducted by low flux hemodialyzer compared to high flux hemodialyzer. Other important risk factors for dialysis-related amyloidosis include old age, type of hemodialyzer, dialyzer membrane material, and residual renal function. For example, high flux membrane and ultra pure dialysis fluid conserve residual renal function and result in better overall clearance of beta 2 microglobulin compared to low flux cellulose membrane. Moreover, patients on HD with low GFR, they are at high risk. Now, the vascular access complication. There are many complications associated with vascular access. Major complications include infection, vascular access bleeding, thrombosis, vascular occlusion, stroke, high cardiac output failure, seroma, aneurysm, pseudoaneurysm, in addition to vascular access related complications like malfunction and stenosis. Infection septicemia occur especially when it is conducted via central catheter. Other complications include venous hypertension, arterial steal syndrome, valvular dysfunction, lesional ischemia, neuropathy, hypoglycemia, and early shunt failure. Therefore, early AV access should be offered to patients with end-stage renal disease because it has several benefits such as reducing the failure rate of fistula and other local complications such as hematoma and seroma. Then musculoskeletal complication. Bone and the muscle pain are the main complaint in patient with the CKD and end-stage renal disease on regular HD, and it is inadequately controlled in more than 50% of patients. Musculoskeletal complications are mainly due to abnormal calcium phosphate metabolism that is aggravated by HD. Also, several other bone abnormalities can arise from the dialysis-related amyloidosis, such as destructive orthopathy, osteonecrosis, musculoskeletal infection, pain before development of peripheral neuropathy, bone cyst, and carpal tunnel syndrome with the flexor tendon contractures, and trigger finger also occur in patients with the CKD and long-term HD. Renal osteodystrophy is the group of bone disease that occur in patients with the CKD. It is characterized by the secondary hyperparathyroidism, osteomalacia, osteoporosis, and soft tissue calcification. Dynamic and aerodynamic bone osteodystrophy in HD patients are two forms of HD-related bone disease. Although osteodystrophy occurs due to secondary hyperparathyroidism and prolonged uremia, it may occur even in normal serum phosphate and calcium concentration. Renal osteodystrophy has been classically related to the severity of hyperparathyroidism effect on the bone. Reduced activated vitamin D leads to hypocalcemia that stimulates parathyroid hormone secretion, increasing serum fibroblast growth factor level. The direct effect of the fibroblast growth factor 23 role is not established clearly in vitamin D activation in patients with CKD and end-stage renal disease. Hyperparathyroidism promotes the bone resorption, causing the dynamic osteodystrophy. Conversely, adynamic osteodystrophy or low bone turnover occur at early stages when parathyroid hormone is not significantly high due to treatment with vitamin D, calcium salts, calcium mimetic steroid, and bone remodeling agents. Dynamic and adynamic osteodystrophy are reported almost at same rate in HD-dependent patients. Stroke. Hemorrhagic and thrombotic stroke occur in patients with the CKD and HD dependency, and its frequency are greater during first week starting HD. The risk factors such as thromboembolism, vascular calcification, hemodynamic instability, and amyloidosis increases the risk of the stroke. The mortality in patients with the stroke who are undergoing HD is approximately 3 times higher compared to patients with CKD who have not started HD. Stroke incidence in patients with HD increases by 5 to 10 folds than the general population, and mortality increased by 3-fold in patients with CKD who have not started HD. Ischemic stroke and CKD are related because both occur concomitantly in old patients with hypertension, hypercholesterolemia, and diabetes. Furthermore, the risk of stroke increases with the more deterioration of renal function and progression of the protein. Moreover, the platelet dysfunction that occurs due to uremia and concomitant antiplatelet therapy, uncontrolled hypertension, and dialysis related anticoagulation increases the risk of hemorrhagic stroke. Furthermore, the risk of stroke increases with more deterioration of renal function and progression of the protein. Moreover, the platelet dysfunction that occur due to uremia and concomitant antiplatelet therapy, uncontrolled hypertension, and dialysis-related anticoagulation increases the risk of hemorrhagic stroke. Undernutrition. Poor nutrition occurs in patients with CKD, and it is not uncommon in patients with end-stage renal disease or HD. The duration of HD is the good predictor of malnutrition and underweight, even with adequate protein supplementation. Undernutrition is still common in patients on HD. Serum albumin and pre-albumin correlates very well with the overall survival rate in CKD and patient dependent on HD. End-stage renal disease-related adynamic bone disease appear to be affected by malnutrition. However, the extent of long-term HD effect on this process remain open to debate. Also, vitamins and mineral deficiencies such as zinc and selenium were reported in patients on long-term HD, and these were thought to occur mostly due to malnutrition and reverse osmosis water purification. Food restriction, appetite loss, nausea are the other causes of malnutrition in patients on HD. Malnutrition is reportedly second cause of death after CVD in patients on long-term HD. Now the next is disequilibrium syndrome. Disequilibrium syndrome is the infrequent neurological condition in patients who have newly commenced HD, although it may still occur in patients on long-term HD. High intracerebral urea level has been suggested to be the main driver for disequilibrium syndrome, with additional contribution from inflammatory cytokines and other putative inflammatory mediators. High intracerebral urea concentration at pre and post dialysis period lead to fluid movement into the brain, resulting in brain edema. Disequilibrium syndrome often manifests as weakness, dizziness, nausea, vomiting, headache, muscle cramps, and behavioral changes, and or abnormal mental status. Disequilibrium syndrome is usually a short-lasting complication that either improves but mostly leads to death if it is not properly dealt with. IV saline is sometimes used to raise blood pressure along with mannitol injection to relieve swelling and pressure around the brain. Patient having the pre-existing cerebral edema, hyperosmolality, metabolic acidosis, hypernatremia, hyperglycemia, and those who have active neurological abnormality are more susceptible to develop disequilibrium syndrome. Thank you.